We did a retrospective study on patients in the Cleveland Clinic system who identified who switched from a high or moderate efficacy DMT, which included any of the monoclonal antibodies or oral medications except teriflunomide, and compared those to when they de-escalated to a lower efficacy DMT, which we included any of the platform injectable therapies and teriflunomide. And then looked at annualized relapse rates, MRI activity, disability scores, and patient-reported outcomes as well. And then we used a non-inferiority statistical method to try to prove that de-escalating from DMT1, a high-efficacy DMT, to DMT2, a lower-efficacy DMT, was not inferior, was non-inferior. And we found most of our results were not significant, but tended to show that in terms of annualized relapse rates and disability, that it was not inferior to switch from a high efficacy to low efficacy DMT2. There was one significant finding in terms of moderate or severe T2 lesion burden, which was significantly non-inferior during that switch. So overall, we think that it is a safe possibility for a number of patients. We just need more trials, and ideally like a randomized controlled trial to identify what patient population that would be most appropriate for and what DMT people should be escalated to. Well, now the field is really changing into starting this early, highly intensive therapy. So early in the disease course, first DMT will use monoclonal antibodies and things that are pretty, potent DMTs. So the question is, if somebody's been on that for 10, 15 years, what do you do after that? So this is trying to answer that question. And there's studies looking at discontinuation of DMT, like the DISCO-MS study that recently came out. So that answers part of this question. Is it safe to stop a DMT? When is it safe to stop a DMT? But there's a gap in the middle. What do we do in between the early, highly effective treatment and discontinuation of DMT? So I think that's where de-escalation fits in. Yeah, that's what we were looking at, going from the highly effective to the more low or moderate efficacy DMTs. And again, the question is, it's always like risk benefit. So usually early in the disease course, when the patients are younger and healthier, the risk benefit ratio of monoclonal antibodies is definitely on the side of the highly effective DMT. But as patients get older, as they have immune senescence, as the disease naturally kind of becomes less active, what is the safest choice for them is what we're trying to answer. Yeah, well, again, it would be nice to have a randomized control trial. This was just a retrospective chart review, so definitely that. During my presentation, I brought up the possibility of even a dose de-escalation or titration. So instead of changing DMT, could the dose of the monoclonal antibody or either the actual dose or the dosing schedule be titrated, and could that be a version of de-escalation? I think would be an interesting question to look at as well. I think it's just always, every year reconsidering that risk benefit of, is this the best medication for you in terms of your disease activity and your risk profile, and really just readdressing that with the patient every year to determine, what the best sequence of DMTs for them. And then we're coming out with so many new DMTs, and this conference is all about the BTK inhibitors, so where are these new DMTs going to fit into the sequencing? And even with like stem cell transplants that are being used now too, how is that going to fit in? What do we do with those patients 10 years later? I think are all interesting questions. So we're all really excited about the BTKs to see the results of those phase 3 trial, especially in progressive MS. I think that's really the big thing, because that's really where we're lacking a lot of treatment options, and it's been a lot of disappointing trials before, so fingers crossed that there's some good evidence for the progressive disease. I think, like to your point of personalized medicine, really identifying the most appropriate patient populations for each of these choices, for starting early highly effective therapy, for de-escalating, for discontinuing the progressive patients. A lot of our baseline characteristics and studies have looked the same for many, many years, but that's not necessarily representative of the MS population. So I think really trying to hone in on what patient population will respond best to these different choices is important. We're getting better at it, but there's still a lot of room to grow in terms of the diversity in our clinical trials and who we include to look at.